Good morning, everyone. Thank you for joining in person as well as virtually for our DeBakey Heart and Vascular Grand Round series. And before we start, just some housekeeping issues. Please use the microphones to ask questions at the end, and we are also broadcasting it live to our worldwide audience via Vimeo and YouTube online. And if you like, subscribe, and share our YouTube channel. For our viewers, if you have questions, you can text highlighting some of our upcoming training activities. There is an adult congenital heart disease hand-on labs on April 4th, Re-Evolution Summit on April 10th, and cardiology for the non-cardiologist one-day seminar on May 17th. So it is my true pleasure to introduce my dear friend and colleague, Dr. Erica Spatz, who is an associate professor of medicine and School of Public Health at Yale University. She is also the director for Cardiovascular Prevention Program and the Remote Monitoring Program in Cardiology. Also, she is the deputy editor at. Very fortunate to have known her for almost 14 years. Senior fellow, helping her understand how to take the sheets out after left heart catheterization, and hence she grew fond on the pressure check, and that is the name of her large PCORI study. She's the national PI of a large PCORI study, 4 centers, trying to get a sense on what are the more important things from a health system and community working together for controlling blood pressure. Now, I would say that there are very few people who have influenced my thinking, and Dr. Spatz and the role of shared decision-making and informed decisions that happen in our conversations with the patients, and definitely a lot of insights, what it means thinking about factors outside the health system and how critical they are, and what type of processes would be needed for us to achieve prevention truly at a population level scale. So on that regard, we should be talking about prevention and, of course, how should we look at the future with fresh eyes. Thank you so much for coming here.
Thank you so much for that introduction, and it's so wonderful to be here, really at the epicenter of so much important science that's happening, and to be with good friends, and thank you for hosting me. The title of my talk is Cardiovascular Disease Prevention 2025, which of course is way too big of a topic for any 1 hour. So I'm just going to cover a few for how we can integrate all of the exciting new studies and novel therapeutics that are coming our way so that we can help prevent disease. These are my funding disclosures, otherwise no other disclosures. So today I'd like to really largely talk about bridging preventive cardiovascular medicine with population health and review some traditional approaches to population health, discuss new diagnostic tools, new risk scores, use of imaging, new conceptual models that focus on obesity, and enhance our understanding of risks associated with lipids. And then really demonstrate how community engagement and digital health technologies can bridge preventative medicine with population health. So climate change is happening at a rapid rate, and we've been vulnerable. Many of our colleagues have been affected by the Palisades fires, and we're seeing the effects of extreme heat, extreme cold weather that have both acute and chronic effects, and we need to be on the lookout for our patients' cardiovascular health. Of course, poverty and income disparities are also at large, and we're fighting against how to improve access to care and how to address a lot of the social determinants that are leading to poverty. And then our obesogenic environment is leading to these rising rates of obesity, where by 2030, half of the US population will qualify as having obesity. So this was a report card that came out of JAC that also just highlights some of the inequalities in cardiovascular care and the excess deaths that are disproportionately experienced by Black Americans in our country. This report estimated that there were about 800,000 excess cardiovascular deaths. That's taking the same diagnoses, the same severity of diagnoses, and looking at survival post cardiovascular events, and finding that there's nearly 1 million excess deaths that potentially could have been prevented with about 24 million years of life lost. So we have big tasks when we think about preventive cardiology, and these can feel really overwhelming. And if we look at a population health approach, how can we sort of flip the script to a more healthy society? These are 5 communities that many of you may be familiar with. Do you guys know these are our blue zones communities. These are what we would maybe consider positive deviants. So, if you think about a distribution curve, right, you have your outliers, and we usually don't pay attention to those outliers. But in qualitative research, we're really interested in who's a really high-performing country or hospital, and what are they doing that's unique that makes them an outlier. And that's actually how they found these communities. These communities had excessively long longevity. And they found that there was, in these communities, commonalities. A lot of intergenerational living, high physical activity, low stress, whole foods, plant-based diets, and such. And so, can we learn from these communities about how to lower our rates of heart disease? Is this at all possible to achieve? So we have a few examples from our population health literature of places that have reversed cardiovascular disease at the large geographic level. One of the ways that we think about how to prevent disease is Geoffrey Rose's two-level approach model. He was a British epidemiologist, and he talked about sick populations and sick individuals. So at the population level, we are thinking that the cause of disease is at the societal level. There's things that we're all exposed to, and our strategy is that small changes, but in all members, can actually have big effects on health outcomes. And these are going to involve structural changes and policy changes, environmental changes, and that's great. We need that. But the limitation, of course, is that it doesn't target high-risk individuals. So you need to complement that with an approach that really reaches sick individuals. So this is to say that, there's causes that are genetic or biological that put specific people at higher risk for disease, and that those people are going to need special attention. They're not going to be helped by, massive policy changes. They're going to need us to work with them one-on-one. And so this kind of dual approach is what epidemiologists would use in order to try to flip the script for these big public health problems. So if we take a sick population like North Karelia in Finland, this is a kind of classic case example where Finland had the highest rates of smoking, hyperlipidemia, hypertension, MI, and premature death in the world in the 1970s. And what were they able to do was to reduce their mortality by 84% from 1972 to 2014. And when we kind of look at these statistics, basically what you're seeing is North Karelia, and then the intervention in 1977 was extended across Finland. And you can see that both groups really declined rapidly. And so the question is what's the backstory? So in 1972, there was a national coalition to reduce these rates of heart disease, and they hired somebody named Dr. Petapuska, and he consulted Geoffrey Ross, and he said, how can we change these rates? And they said, well, you need a societal approach, and you need an individual approach. So he took the data into the community. He went to these women's groups where they had these cooking and recipe parties, and they were called this Martha's organization. They called them longevity parties, and they talked to them about nutrition. And they sought out all key opinion leaders to start messaging around healthy lifestyles. And then they worked with industry and supply chain, because post-World War II, many people came back and were given land to harvest, but in order for it to be viable, they wanted something that was year-round. So they said, you know what, replace all those grains and vegetables with cattle and pigs, and let that be your, what you're going to farm. And so there was enormous amount of meat and out of the dairy farms, trans fats, and they were able to affect that entire supply chain through incentives. They did smoking laws and bans, and they established a hypertension registry where every person in the country had their blood pressure measured. And in the first year, the mean blood pressure was 176/102. Not so unusual for the 1970s, because of course our blood pressure guidelines had us treating very high targets, but really indicative of this very, very unhealthy population. And now, you know, I think if we think of like the Scandinavian countries and Finland, we think about like some of the healthiest countries and places with the most robust registries that we're learning from, if we think about like Sweetheart and other places. They really had started much earlier than we are in terms of flipping the script. We have but a few examples stateside. We have the trans fats ban that was first instituted in New York City in 2006. It was not until 2015, however, that the FDA finally banned trans fats. This was a study that was led by one of our former fellows and now at University of Michigan, Eric Brandt, looking at the effect in counties that adopted trans fats and then that didn't adopt trans fats from the New York City ban. And basically, they were able to show that there was about a 6% reduction in MIs starting about 3 years after the trans fats policies went into place. Some other examples at the population health level are some of the work that's being done in China around salt substitutes. And these studies, this was a cluster randomized trial in about 600 villages in rural China, where they took people who were high risk. They had either had a stroke or had poorly controlled blood pressure, and they randomized those villages to salt substitutes versus no salt substitute and showed declines in risk for stroke. So these are just but some examples, but obviously they're hard. And if you're any practicing cardiologist, it's very hard to implement these kinds of things locally or even, let alone nationally. But you know, that's not the full story, right? Because these things are important, but then again, we have our other side. So what I want to say is that if we can shift to more of a population health model, I'm not going to be talking about well-being today, but well-being, really the pillars of physical, social, and mental well-being. When we think about population health, we want to have that more holistic model. How do we promote that at the societal level? And then again, how do we get down into personalized prevention? So this idea that one needs the other. Let me shift a little bit and just talk a little about personalized cardiovascular risk reduction. Now, this is the stuff that probably you all are much more familiar with, but our task as preventative cardiologists is to consider cardiovascular health throughout the lifespan. I'm often thinking about this, especially in terms of women's cardiovascular health, because there's these milestone moments of pregnancy, menopause, healthy aging that we want to leverage thinking about population health. And we need the same in men as well. This is a case that, since it's grand rounds, that I wanted to introduce and think about with you all. This is a 51-year-old man who's asymptomatic, and he's referred for severe hypertension. He comes into the office, his blood pressure is 167/100. So he's going to need a personalized approach, right? My salt, even if he's, lives in a community with salt substitutes and trans fat bans, he's not going to have that much benefit to the degree that he needs to protect him. His BMI is 34. His lipids don't look too bad. They're generally okay. His A1C is 6%, so he's pre-diabetic. He has an unhealthy diet, not very active, former smoker, has some poor sleep quality, has a lot of stressors in his life, finances and relationships, and he's got a significant family history. And this is really where I think, our charge comes from, is that family history. I can't let this guy go without aggressive treatment, knowing that his father died at 59 of an MI, and his brother recently had a stroke. Oh, and his paternal grandmother had an aortic valve replacement at 66. So these kinds of things are important as we guide our intensity of therapy. You are no stranger to our traditional risk factors as well as our risk enhancers. And I think that, what happens when you refer to a patient for prevention is that we're often in that risk enhancer group, really thinking about what else is happening in that patient's life beyond the traditional risk factors that may inform our understanding of risk and then how aggressive we are at treating them. The pooled cohort equation is something that is a starting point for a lot of people, but probably not always the end-all be-all for us when we're thinking about cardiovascular risk reduction. But still, this is what is out there, and was recently replaced, as you all know, with the PREVENT calculator, which I feel like I need to talk about just a little bit because you may be getting questions, as I am, about what calculator should we use to define people's risk. So the PREVENT calculator, it was recently introduced by the American Heart Association. What's new about it? It's built with more diverse cohorts. There's 46 cohorts. They use both population data as well as EHR data. It includes over 6 million people, and it has a more expansive age range. So the lower age limit moved from 40 down to 30. And we're capturing some additional risk factors that the PCE doesn't. So we have BMI and GFR. And then there are these optional risk factors of urine albumin creatinine ratio, A1C, and then zip code, which with the zip code data, we can capture social deprivation index. And this is really to try to better understand where people's risk comes from that is more social, related to their social circumstances. There's been a lot of debate about whether or not we should include race in any of our risk calculators. And race is fraught because it's often assigned by somebody who doesn't know their actual person's race. And race is more genetic versus social. When it's marked, the risk associated with race is social rather than genetic. Yet we're thinking that it's genetically determined based potentially on how somebody looks when we assign it in an EHR. So the actual label can be incorrect. And then the risk associated with race, as we know, is being a social construct, really complicates things, right? Because we want to understand why is that person at higher risk. And so in this calculator, race is taken out, zip code is put in, and through zip code, we can learn more about what that person's local environment may or may not look like. Now, there's a lot of issues with this as well. On the one hand, PCE was thought to overestimate risk. On the PCE side, now there's concern of underestimation of risk. So a lot of people's risks are downgraded, and fewer people are now eligible for blood pressure medication and lipid medication. So we're not totally sure where you get it, whether we've gotten it right. In our patient that I introduced before, his risk actually was 8.1%. I hate those decimals because it implies precision that we don't have. But anyway, that was his risk. And when you put him into the PREVENT calculator, his risk went down to 5.4%. So that's a difference if he's going to be eligible for different therapies based on those two things. And if you add in microalbuminuria and zip code, we can increase his risk a little bit. So actually with his, he does have microalbuminuria, his risk went up to 10%, and with his zip code as well, that went to 10%. And if I put in a high income zip code, it went down to 8%. So let's just talk a little bit about social determinants. This patient lives in a neighborhood in New Haven called New Hallville, where the life expectancy is 10 years lower than the community that I live in, which is right next door. And these disparities exist in most modern American cities, where his life expectancy is 74, my life expectancy is 84. My neighbor wrote a book called The Other Side of Prospect, and this literally applies to us because we live on the other side of Prospect, really trying to understand the depths of what's happened in blighted communities economically, around gun violence, around food insecurity. And it really causes us to take a better look at what the full exposome is that the person is being exposed to. The exposome refers to the total environmental exposures from the time that somebody is prenatal to the time that throughout their life. So is it climate? Is it the stressors in life? Biological stressors? So coming back to the risk calculator, I like it because it does help us to take a pause and reflect on some of the reasons why our patient's risk may vary once we put that zip code in and see and learn more about what is their lived experience to better understand their risk. So my patient comes from a very high-risk community, so now I'm doubly worried about him. He's got a bad family history, he leads an unhealthy lifestyle, and he's going back into a community with a lot of stressors. We do a calcium score to guide the intensity of his prevention, and it's 185. Okay, so we know, thank you to Dr. Nasser's work on so many levels about the value of a calcium score, which is not exactly put forward in the guidelines. It's either all or nothing, but really the calcium score does reflect the risk, and the higher the calcium score, regardless of people's ASCVD risk, there is meaning in that, and this can help us to determine how low to go with our LDL goals. It's interesting in that there's still never been studies, prospective, rigorous studies to show that statins reduce events in people with CAC. This is sort of one of an observational study, which is, I think, one of the strongest studies out there, but it still has a lot of limitations. They took about 17,000 patients free of CVD who underwent initial CAC scoring at Walter Reed Medical Center. And then they looked to see who was prescribed statins and who wasn't, and they matched them using inverse probability weighting. And basically what they did was looked for MACE. And what they found was that patients with CAC who were on statin within 5 years of their CAC testing had a significantly lower rate of MACE by about 25%. And patients without CAC had no MACE reduction when they went on statins. So again, if statins, the power of zero really kind of comes to light here, because people without CAC did not derive benefit from statins. And they found that the true value for number needed to treat was when the CAC score was above 100. So this can help us to titrate the degree of prevention for our patient. An emerging question that I face a lot, and we were talking about over dinner, was, are we starting prevention early enough? So CAC is sort of is a stabilized form of plaque, but is preceded by much earlier forms of plaque that are much more vulnerable. And I think we all know that we are kind of under pressure to detect these lower levels of plaque and to figure out what to do with them, right? So we're ordering a lot of coronary CTAs to better understand whether there's soft plaque, non-calcified plaque, and whether we should get an earlier jump on prevention. There's little data to guide this, but it is coming fast and furious, probably mostly into your radiology suites with a lot of AI technologies that can do plaque characterization. So I'm just kind of very much quickly glossing over this idea that we've known about this for a long time through IVUS and then standard coronary CTA imaging, and now we're using AI augmentation to further classify plaque. And the question is whether any of these things are increasing the value of what we're doing and whether we are getting an earlier jump on prevention. In the Scott Heart trial, they took about 1,700 ambulatory patients with stable chest pain, had them undergo a coronary CTA, and looked at their plaque. And then they looked to see who developed MACE in the future. And here they're showing that of the different kinds of plaque features, the low attenuation non-calcified plaque was the highest risk plaque and the most predictive for MACE. And they went further to say that there's actually like a strata, like where above 4% low attenuation plaque was associated with very high risk of MACE, versus under 4% was considered low risk of MACE. So this is some data to demonstrate that there may be some value in terms of risk stratification, but is it at the margins? In the PROMISE trial, which you all are familiar with, which looked at CCTA versus standardized ischemic evaluation in patients coming in with chest pain, they also demonstrated that there was about a low density plaque was associated with a 70% increased risk of MACE, which was independent of cardiovascular risk factors as well as obstructive CAD. And they also looked at subgroup analyses, finding that this kind of information was of more value in younger patients, no surprise because of less calcification, women, and those with non-obstructive coronary artery disease. So should we be using coronary CTA for screening in our patients? Would we be getting a better jump? It's still expensive. There's radiation exposure. There's the cost of these AI technologies that's not always covered, although that recently changed, as I know, with Medicare. But there's no outcomes data that treating according to plaque classification and progression improves outcomes. So that we're still waiting for. And then there's this question about once we start testing, how often would we do follow-up testing, and where do we go with all of this? So we need a lot more data on this subject, but it is coming fast and furious into the prevention world. I'm going to shift also to other things that we would test in this patient. So we're doing the calcium score. We're deciding not to do the coronary CTA. And the other thing is his risk fully captured, or is there residual risk that we're not addressing? And LPA is, as you know, composed of apolipoprotein B, which is an LDL-like moiety, and it's covalently bound to ApoA. And it's proatherogenic, so it's pro-inflammatory, pro-thrombotic, and it can lead to increased MI and stroke, as well as calcific aortic stenosis. And in our patient's history, if you remember, he had a father with an MI at 59, a brother with a stroke, and a grandmother with early aortic stenosis. So for all of those reasons, I'm highly suspicious that he has elevated LPA. In addition, his lipid levels were not that abnormal. So I wondered if there was something else that might explain why he has a lot of CAC. So in the population, about 20% of people will have an elevated LPA. And this poses another challenge for us prevention cardiologists, right? So 1 in 5 people are going to have LPA elevations. And if we follow the European guidelines where everybody is screened, you have a lot of people who are really stressed out and don't know what to do about those elevated LPA levels. So that's currently what's happening, is that PCPs are checking it, and then I don't know what to do with the answer. And so here we are. LPA levels are higher in African Americans or Africans as well as South Asians, and it seems that risk is the same, so that the same levels of LPA are associated with the same risk factor for cardiovascular outcomes. So we need to take it seriously, even though you may see higher levels in those populations. The PCSK9 inhibitors do lower LPA levels by about 30%. That was seen in the post hoc analyses of Odyssey as well as Fourier. But currently there are no LPA-directed medications, although they are in the pipeline, which of course is the tail wagging the dog now that we're having newer therapies with small mRNA molecules. We are seeing that there's a bigger push to check LPAs in preparation for these new medications. And that seems to always be the case in cardiology. So who should we screen for LPA? Should we screen, and who should we screen? I like to screen people who have a family history of premature coronary artery disease, or who have FH, because it's high, LPA levels tend to be higher in people with FH. Or who have an unexpected atherosclerotic burden or early calcific aortic disease that don't match their other traditional cardiovascular risk profiles. As I was noting, there are some novel mRNA therapies that are targeting LPA. Olpasiran in the OCEAN trial has been shown to reduce LPA levels by a lot. with getting up to nearly 100% reduction and 95% reduction in some of the other trials. So these are coming down the pike and will be available. And the question is again, how do we judiciously allocate these therapies to whom when they become available? With regard to LPA testing, there's been a lot that is being written in preparation. I'm directing you to one of these educational tools that I think does a really great job. It was the first time I really saw people kind of get ahead of this, which is, this came out in atherosclerosis. You'll recognize a lot of the names, the people on this document, but they answer the 20 most frequent questions that come up around LPA. And they're in the different domains of epidemiology, how does it inform risk, what are some of the measurement issues around LPA, and then how do we manage LPA? And then they even have like a risk score that you could combine some of the traditional risk factors in LPA to get a better estimate of your patient's risk. So I often use this. I will sometimes even share it with patients because it comes up a lot and causes a lot of angst. Pausing now, summarizing, have we fully addressed this patient's risk? We have several risk enhancers that we've uncovered. He's got an elevated CAC score, he's got an elevated LPA, he has proteinuria, he's got a lot of stress in his life. And for the most part, our traditional approach would be start statins. His CAC scores are above 100, so we'll also add aspirin. We'll manage his blood pressure. I haven't talked about that yet, but I'll save that. He has prediabetes, and we could do lifestyle or metformin. We can ask him to do some meditation. We can refer him to a sleep study, and that's our basic prevention. But we're probably missing a big source of why he's at risk for all of these cardiovascular risk factors. So I'm going to talk a little bit more about obesity and then sort of talk about new models of care as we go forward. So as you know, the cardiovascular kidney metabolic syndrome has been put forth through an AHA presidential advisory led by Chiati and Demelli, who is putting a new syndrome on the map for us. You may have known this, some parts of this is syndrome X or cardiometabolic syndrome, which we've been using more so in the last 10 years, and now really adding the kidneys into the mix. My husband's a nephrologist, so he's like thrilled to hear this, that finally they get like some place in the world of cardiovascular disease prevention. But this idea that there is shared etiologies of these three systems, and it's not only leading to cardiovascular events, but there's higher rates of MASLD, which is the new name for fatty liver disease. There's higher rates of cancer, higher rates of cognitive decline, and of course, kidney failure. So is this just like repackaging what we already know, or are there new learnings to be derived? Some of what's driven this change is that we haven't really, I would say, in our training, really acknowledged the risks that are associated with obesity, diabetes, metabolic syndrome for a long time. Oftentimes we think that, when a person has obesity, that their risk is conferred when they develop diabetes, when they develop hypertension, when they develop the sequelae of obesity. But we're learning that there's a more direct connection. So just a few statistics to put in front of you, because I think that I didn't have these statistics in my head, but I'm really taking them to heart. So higher degrees of obesity are associated with progressively premature mortality. So grade 3 obesity, BMI over 40, is linked to a median survival reduction of 8 to 10 years. That's a lot. Men and women with diabetes have a 13 to 14 year shorter lifespan, and the earlier onset of diabetes is associated with greater survival reductions. And middle-aged adults with stage 4 kidney disease, GFR 15 to 30, have a greater than 20-year shorter lifespan. And death from cardiovascular disease becomes the major competing mortality for the development of end-stage renal disease or dialysis. So these are pretty sobering statistics, especially thinking about half of our population is going to have obesity by 2030. and of course the risks that are the downstream risks that will be associated. So you've seen this a lot. These are the stages of CKM, and you'll notice that in stage 1, it starts with excess or dysfunctional adipose tissue. And leading then to stage 2, which is our metabolic risk factors and CKD, then stage 3, which is our subclinical cardiovascular disease. So these are CAC, or measures of echocardiographic measures of subclinical heart failure, and then stage 4, which is our clinical cardiovascular disease. And oftentimes we as cardiologists are not seeing them until they're at stage 3 or stage 4. But really, if we want to have an opportunity to prevent disease, we need to get to them earlier, before they have onset of disease that can't be reversed. I can't reverse his CAC, but I can help prevent its progression. And if I get to them either in stage 1 or stage 2, I might have a chance of preventing stage 3 and stage 4. I will just say not all of the metabolic risk factors, hypertension, for example, go through this pathway, but this is a very common pathway at the population health level. So let's just talk a little bit about visceral and ectopic adiposity. So we learned not too long ago in the 1990s that fat is not inert. It's an active organ. And fat increases inflammation, it increases adipokines, lipids, it increases sympathetic activity, it activates the RAS pathway, and we have oxidative stress. Visceral and ectopic fat is different than subcutaneous fat, although the two are highly correlated. So visceral and ectopic fat, we're talking about intrahepatic visceral fat or intramuscular fat. And ectopic fat can be fat depots, localized areas that where fat accumulates, where it shouldn't. And these visceral and ectopic fats correlate more so with abdominal waist circumference, which is why you're going to be hearing more about that, and increases insulin resistance and diabetes, as well as atherogenic dyslipidemia, cardiovascular disease. About 30% of IL-6 is produced from visceral fat. And so IL-6 creating CRP and then leading to cardiovascular, greater inflammation, cardiovascular disease. Our understanding of visceral and ectopic fat is rapidly evolving, and we may be seeing these more characterized on CT scans. We can find them on DEXA scans. But right now, we're still pretty reductive in using BMI. So all of our obesity trials are using BMI, even though there's a lot of heterogeneity with visceral and ectopic fat. So you could still have a person with a normal BMI, high visceral adiposity, and they're going to be at higher cardiovascular risk. And you could have people with a high BMI who have low visceral adiposity, and they would be at low cardiovascular risk. So BMI may be misleading, and we may need to go further to further characterize risk in our patients. And this may be especially important in the South Asian population, where we see higher rates of diabetes and atherogenic disease for those same levels of BMI, and that's why we have shifted our thresholds for what defines increased waist circumference and increased overweight and obesity and in that population. Just somewhat of a quick note. So with fat deposits, the visceral fat that is intrahepatic or intramuscular has more to do with some of the more systemic and metabolic effects, whereas the localized fat, which you're probably hearing a lot about, perivascular fat, pericardiac fat, those are areas where fat is localized in the heart and are having more localized effects, localized inflammation, and increasing risk. So how should we treat obesity? What should we do about it? For a long time, we've been doing diet and exercise, and it hasn't been working. In our two best trials, the DPP, the Diabetes Prevention Program, and Look Ahead trial, which actually achieved pretty good weight loss compared to a lot of other studies. In the Look Ahead trial, the mean weight loss was about 6 to 8%, depending on when you looked, what time point. we can see that there was pretty good weight reduction initially, but there's a lot of weight regain. And there was the trial was stopped early because of failure to prevent MACE. And when we've looked at diet and exercise trials across time, we see kind of these same trends. Initial weight loss successful, but again, this weight regain, and also no effect on cardiovascular outcomes. So we need to kind of take a pause and say, like, what have we been recommending for our patients, and how have we been potentially setting them up for failure to continue to beat them on diet and exercise, which are so important for cardiovascular health, but maybe not effective for treating obesity. So much of what I've learned is from my colleague, Dr. Anya Yastrobov. I'll just play like a little clip from her because she is so eloquently talks about obesity. I'll show you a clip of her on Oprah, and then she was invited back to do 2 one-hour sessions with Oprah. And I tell you, this is for a lay audience, but every doctor and nurse should listen to her description of what's happening with obesity, because it's so well said. But, we are better understanding obesity as really being a neurobiological disease. And so our brains in the hypothalamus have a fat mass set point. And we're trying to defend that fat mass set point. And so it's kind of like a thermostat where we are adjusting energy storage and expenditure to maintain that temperature through a very coordinated system that works with our gut. I'm going to just play you just a short clip from this because I think it's sort of important, and I've been trying to bring this language more into the clinic to help explain to my patients why we are doing a backshift on how we're treating obesity.
Okay. And hormones tell our brain how much energy we're storing. These hormones in our body that basically get stimulated when we eat food. They're nutrient stimulated hormones. They tell our brain, are we hungry? Are we full? How much energy are we storing? So there's this great, amazing communication and this amazing biology.
So we should thank our body for
We should thank our body. We should thank our body.
Thank you for all that, yes.
And here's the deal. So then people are like, well, if we have this beautiful system and our brain wants to carry a certain amount of energy or a certain amount of fuel, then why do so many people have obesity? It's our obesogenic environment. This environment that is filled with highly processed food, lack of sleep, all this stress, lack of physical activity, all these different things in our obesogenic environment contribute to this. So what does that tell us? Well, 2 things. One, it says we have to fix our environment. We have to. But we have to.
Yes.
But for the people who already have obesity, we need to offer them treatment if they would like it. We need to offer them choices. We need to give them treatments that target that biology.
Because the willpower is never going to do it.
Nope.
And how long have y'all known this?
It's not something that we've been hiding. We're learning more. And eat less and move more does not work. It is not about willpower. It's about biology. It's always been about biology. We just didn't know. Now.
So that's like a little preachy, but it's true because this is the kind of frame shifting that I think a lot of us need to do when we think about, wait, are we really going to start by treating obesity in this CKM model, right? Who should we treat? Why should we treat people? And how do we combine it with lifestyle? How do we understand the value of diet and exercise at the same time that we're recognizing that it hasn't been effective for treating the biology of obesity? So when you look at I'm going back to the presidential advisory report and look at their stages, I'm showing you stages 1 through 3, they talk about lifestyle, GLP-1s, and bariatric surgery at stage 1. And then, there's a whole host of other medications that they're talking about in stage 2, including our SGLT2 inhibitors and such. So the treatment is really starting very early. I'm not going to go through these, but there are lots of studies that are looking at not just weight loss, but cardiovascular outcomes. You're probably familiar with the SELECT trial, which was semaglutide in people who have obesity but without diabetes. They took 17,000 patients, randomized them, and looked at death from cardiovascular disease, MI, and stroke. And in this group, we saw a 20% reduction in cardiovascular risk, again, just with semaglutide. There are dual incretin therapies, our GLP-1, GIPs. This is like tirzepatide, and we recently, they have yet to be shown reduction in MACE, but those trials are ongoing. This medication was recently approved for obstructive sleep apnea with significantly lower rates of the apnea-hypopnea index. And we're also seeing it used, obviously, in both of these medications for heart failure. This is just showing you some data from SURMOUNT that was looking, that shows you that there's about a 20% weight loss with tirzepatide. We're also seeing declines in blood pressure, some modest declines in lipids. Virtually anybody who has prediabetes in these trials, virtually nobody goes on to develop diabetes, and we see reductions in A1C in those with diabetes. So the nutrient-stimulated hormones are coming out one after the other. There's a lot that are in the pipeline, including some triple hormone therapies like retatrutide, and so be on lookout for these other kinds of medications. Dr. Nasser was mentioning with Dr. Nasser, we're both editors at JACC, and we recently did a series called The Obesity Revolution, and there's a lot of these great studies and videos talking about obesity. So in my final time, I just want to discuss a few thoughts on, again, bridging prevention with population health and the role of the community and digital technologies. So I didn't talk about hypertension care, which actually happens to be the main thing that I focus on, but I didn't talk about it in the personalized prevention because I think we need a major shift in how we manage blood pressure. This is what it mostly looks like. It's in person, blood pressure is taken quickly, it's rushed, and the end result is that if you look in our health systems, about half to about 2/3 of people have their blood pressure under control, and that's when they're coming into care. If you look in the community, only about 1 in 4 people have their blood pressure under control. Epidemiologically, we are getting worse in controlling blood pressure. So what we're doing at the bedside is not working at all. And it is the most preventable, modifiable cause of heart attacks and strokes, and the most potent risk factor. So we've turned a lot to home blood pressure monitoring. When we check office measurements, up to 30% of people will have elevated blood pressure in the office, white coat hypertension or white coat effect. But also because we miss hypertension, sometimes it could be lower if a person is sitting there waiting for us for an hour. So we may miss blood pressures that are elevated outside of the office, called masked hypertension. And if we do home blood pressure monitoring, we could be more efficient in our titration rather than having a person come back in 3 to 6 months, which often even doesn't happen. What about 24-hour blood pressure? We know blood pressure is going up and down. In order to diagnose masked hypertension, we often need to get the blood pressures that are happening during the day. Nocturnal non-dipping is when the blood pressure does not dip by more than 10% at night. So we still use 24-hour ABPM to diagnose these things, and it's important because masked hypertension is actually pretty prevalent. These are data from NHANES showing that if your blood pressure is between 130 to 140 in the office, there's about a 30% chance that it's even higher outside, so about 30% masked hypertension in that group. And there's a lot of disparities around masked hypertension, such as in the Jackson Heart Study, 54% of people aged 40 to 79 who had a clinic blood pressure less than 140/90 had masked hypertension. So when we think about 24-hour ABPM, I'm often thinking about, who do I need to detect masked hypertension in? but still it comes with a high burden of capturing all this data, and getting a blood pressure cuff on somebody for 24 hours is still challenging. This is a study by Daiichi Shimbo that looked at which is the most predictive of left ventricular mass index. They studied 3 office blood pressures on 3 separate visits versus 21 days of home blood pressure monitoring versus 2 24-hour ABPMs. They did this in about 400 patients in New York City, pretty diverse population. And what they found was that home blood pressure readings were actually the most predictive of LV mass index. So this was helpful for us in kind of also validating why remote blood pressure monitoring might be sufficient when we're thinking about how to capture these out-of-office blood pressures. If you're not able to, you should know from this study that the blood pressures from 2 to 3 visits, as compared with a single visit, were much more predictive of LV mass index. But 1 week of home blood pressure monitoring was enough, 1 week, to be strongly predictive of LV mass index. So we don't have to do a lot, we don't have to burden our patients. We developed a home blood pressure monitoring program at Yale that refers people, gives them a cuff, has it sync into the medical record, and then we do telehealth visits with our pharmacy team. We work under a collaborative drug therapeutic management program that allows pharmacists to prescribe on our behalf. They review the blood pressures and manage the patient's blood pressure. Recently, we had a grant from the CDC called REACH, which is Racial and Ethnic Approaches to Community Health, and we also screen for social determinants of health, and those who identified as having one of them were referred to our community health worker. We started this program back in 2018, and when the pandemic hit, we had a ton of blood pressure cuffs, and we brought them over to our labor and delivery floor and revamped our program to make it fit for women with hypertensive disorders of pregnancy. So that same team, that same model of pharmacist, community health worker, was being extended to women in that vulnerable 6 weeks postpartum to manage their blood pressure. We never got to our employee health screenings, but we went to the community because we realized we were missing a lot of people who weren't coming in and we weren't extending this program to. We were first meeting them in the hospital with heart failure after uncontrolled hypertension. So I'm just going to close with that work in the community and in postpartum women led to 2 studies, one of which is called Pressure Check, which is what Houston Methodist is a site for, one of 4 sites. And I just want to share with you just a bit of information about Pressure Check. This is a study looking at blood pressure control using 3 strategies: usual care, remote blood pressure monitoring versus remote blood pressure monitoring plus a community health worker. The 4 sites here, Yale, Houston Methodist, Mass General, and Centara Health, which is in Virginia. The idea is that the 4 health systems are partnered with 10 community-based organizations, and we do those blood pressure screenings in the CBOs in those community organizations, and then qualifying individuals are recruited into the study. So, for example, this is in a barber shop. They are checking blood pressure. Everyone is given a home blood pressure monitor plus a cellular device that connects into our REDCap database as well as into Epic. And then there's these 3 models of care that are being conducted in a stepped wedge design. It looks the management is done clinically, so it looks clinical, like all the data come into Epic. We can see it in our vital signs flow chart. And we use some protocols that really leverage combination pills in order to treat blood pressure. These are some pictures from your city, Houston. This was on your launch day. You are partnered, I don't know if you know, but with a phenomenal nonprofit agency called the African American Male Wellness Agency, who are out there doing a lot of these screenings, and your fellows and researchers are working with these participants in this model. The 10 community organizations in Houston, I have them on the far right, include churches and community centers and barbershops, and it's been a terrific collaboration. I had a chance to go out there yesterday to one of the churches where there was one of the screenings, And these are health advocates, as we call them, which are otherwise research assistants who are from the African American Male Wellness Agency that are measuring blood pressure and enrolling patients in the study. So from this, we've been extending to our health system remote patient monitoring, not just for blood pressure, but also for diabetes as well as heart failure. This idea of giving people a digital health kit where that syncs into the medical record, where virtual care teams can help people get under good control. I think I'm gonna pause there and wrap up and say that, this idea that there are health system community partnerships, I think is probably where we need to go in order to solve these bigger, larger problems of population health and preventative medicine. So we're seeing a lot of this merge together in some of the community work where we're able to do the personalized risk medications as well as addressing a lot of the social determinants that people are experiencing. So in summary, I think it's an exciting time for prevention, but we need new models of care. In preventative cardiovascular health, we are doing better with personalized risk assessment. We have a ton of novel therapeutics. We know we need to integrate social determinants of health, but we also need to think about the population health approach. And I think to get there, we need these ideas of team-based care, digital health, computational science that's going to improve efficiency, and more implementation science, more report cards and accountability, and greater partnerships with our community, with tech companies, payers, and government. So thank you so much for having me to give this talk. Thanks.
What a wonderful overview of also at the population health. And as you were presenting, and so much extensive. In the setting where the health systems truly we are unable to address that. Do you think that it may be unfair asking the journal prevention, or is it time to create specialized uses then? And how would a health system support those type of enterprises?
Yeah. So, a lot from heart failure, right? A lot of us, of course, it's a high challenge to get people onto GDMT. Extended team models and their labs and start to, and that has been met with that kind of model is probably needed to be extended to cardiovascular disease risk. Do shared decision making. What are the goals? Let's have some shared goals, how we're going to get burden of access in our healthcare system to, allow for those kinds of and the reason why is patients love them because they spend so little time talking about to talk to about them that's just focused on the medical future involves a lot more an investment by the health system right now.
Spectrum and advanced heart failure transplant. So much affect sort of the disadvantaged communities. Care is very low in these. And what incentives can we build for these patients to actually Because if you don't in their own health, outside meaningful differences in,
So what incentives? I think the incentive is trust. And so technologies, bringing people, giving people a digital health kit after. But if they don't have trust, it's very challenging. So what our study is doing, what I didn't mention, is actually with like street cred in their lives who are messaging. We do a good job of that. And throwing more technology at them, a key missing piece. And I think that missing piece is because once that can, the whole thing changes, and a lot of, they're much more.
Sadir Al-Kindi, I'm a preventive cardiology. Question, I hate to be that guy, but they're linked. And while this could make sense for of EGFR, to me, at the individual level. And that actually has been place it with anything that is a surrogate for social determinants to propagating inequity, a risk for cardiovascular disease events. And if you don't identify that, what do you think is the best approach? The second question, which is also linked to this, focused on medical interventions for, have we thought about, and kind of what were your thoughts on intervening on the social determinants of health of cardiovascular disease?
Thanks for active debates on these questions. One of the U.S. Black Americans, there are still disparities. So when we think about with a zip code-based social deprivation index, actually with growing up Black in our country. We can't take our risk models and bring them outside of the. The question is if we just want to capture risk, should we care that we have risk? There may be misinterpretation reflecting a genetic predisposition when it's. So I don't know the answer to that question. And if once we start talking about this and actually be fine. I mean, there could be unintended consequences substituting SDI because intervening on social determinants. I mean, these are hard things. But what I can needle, like we've maximized risk reduction, the tools that we have. But if to food insecurity, outcomes. We're just not. So I don't, as a country, we spend the least on social services and flipped. And
thank you so much for the first-year cardiology fellows. So during the study that you shared, I guess, in patients, statin therapy was not found to be effective. And then my second question is, I think we mentioned that simply willpower is not enough to tackle obesity. So does that mean moving forward I should be telling my patients and then directly start them on some sort of medical care? Thank you.
yeah. So in that observational study, there was only 5 years of follow-ups. No CAC, and were placed being on statin in terms of MACE. And when you looked at the group that was 1 to 100, is not on a statin, there was a little bit of risk reduction, like over 100 as compared with CAC. And we still, I think that the predominant cat's out of the bag, there's a process. Extension, we want to stabilize that plaque. So I would say, because I think 100 people for a long study, but we don't have a lot of other prospective, you know, activity and whole foods plant-based diets are effective for cardiovascular health. To bat hard on that, but I don't think that that is solving the problem of obesity. So I'm or to treat fat that most people don't stick to it. So we start with an integrative approach. But most people, when they come to us, see that sometimes they're very relieved not to hear that we're just going to do diet and exercise. Not be shamed into taking a GLP-1, because that's happening as well. Like commonly accepted that people feel like if they're caring about their health, and we need to avoid that as well.